Hello and good morning, everyone. Thank you, SLMA and GMA, for the opportunity. So I'm here to discuss few advances in geriatric medicine and how they are shaping the future of healthy aging. Right. So first we will, this is the outline for the lecture for the next 30 minutes. First, we will explore the aging trends locally and globally. Then we will review the recent advances in managing two common medical diseases, that is diabetes and hypertension. Next, we will look into the significance of sarcopenia, that is an age-related muscle loss, and focusing the integrated, patient-centered, the care in geriatric medicine. That is the key in the management of geriatric population. So this slide shows the significant global trend of the population aging. As you all can see, the bar graph shows the increasing percentage of the elderly population in the world, starting from the approximately less than 5% in the year 1950, and has showing the projected rise to over 16% by the year 2050. Right. So what is the situation in Sri Lanka? So you can, so let me, right. So the people over the age of 60 was 11% in the year 1950, and it has increased steadily since then, and it was projected it will be over 25% by the year 2050. Similarly, the people over the age of 65 years will be doubled by then, reaching 21% by the year 2050 as well. Right. Building upon this demographic shift, this table highlights a significant health challenge within this population, the growing burden of diabetes in the aging population. This chart clearly showed that from the year 1995 to 2025, the steady rise of the prevalence of diabetes from less than 5% to 25% globally. So five-fold rise over decades. So what is the current situation in Sri Lanka with regard to diabetes? A recent study conducted a few years back found out that the Sri Lanka has been the hotspot for the diabetes among Southeast Asian countries, where every 1 in 4 adults has diabetes. How this is relevant to my topic today, the geriatric topic today. The same study found out that the prevalence of diabetes steadily increases with age, where the peak is at the age between 60 to 70. Why older adults with diabetes need special care? Are they different from their non-diabetic peers? Yes, they do. Older adults with diabetes require special care because the diabetes, together with aging, create a vicious cycle that significantly worsens the health outcome. They are at much higher risk of having cardiovascular morbidity and mortality and all-cause morbidity and mortality compared to their non-diabetic peers. Importantly, diabetes accelerated the functional decline, falls, disability, depression, and fractures. Importantly, this population of people with diabetes and old age is associated with increased the cognitive impairment. This is linked with their inability to self-care themselves with diabetes. So that is very important for us as professionals, the medical professional, to assess the cognitive function and the functional level before setting before starting any management strategies, to know their baseline functional and cognitive level. So my diabetic management in old age is based on this ADA guideline 2024. So what is their key recommendation? Their key recommendation is to assess the medical, psychosocial, and functional as well as social aspects of the older adults with diabetes to guide personalized treatment goals and strategies in diabetes management. Older adults can be categorized into 3 groups based on their functional and cognitive status. They are the healthy, intermediate, as well as the very complex or the poor group. Healthy means they have less comorbidities and otherwise they are intact with regard to their functional and cognitive level. Intermediates, they have more the comorbidities and there have been some the impairment in the cognitive and the functional level or status. The very complex moving to their more comorbidities, more impairment with regard to the functional as well as the cognitive function. This classification is essential to provide the individualized management strategies tailored to their specific needs. All the management decisions depend on this categorization, including screening for the complications, setting the therapeutic goals, choices for the pharmacological agents, as well as the recommending the lifestyle modification. Moving to setting the goals with regard to glycemia, lipids, and blood pressure. We'll talk about the healthy group, that is otherwise, apart from the age, otherwise they are fit and well. So you expect a longer remaining life expectancy. So the recommendation is to go for the strict glycemic targets of HbA1c of less than 7 sometimes, if they are tolerating well, or 7 to 7.5. Setting the blood pressure goals for this group, the guidelines now are developing for an intensive blood pressure targets for an otherwise fit and well older population. So of less than 130/80. I will be dealing with this in detail when I'm coming to talk about the hypertension in old age. And talking about the cardiovascular, addressing the other cardiovascular risk factors, lipids and antiplatelets. However, when come to the old age, addressing these lipids and antiplatelets, there are less evidence. And from time to for the benefit, we're talking about the statin, it needs at least 2.5 years. However, this group, we know that we expect a longer duration of life expectancy. This group need the statins unless there is any contraindication for the therapy. Moving to the intermediate group, we expect the intermediate remaining life expectancy. We are not focusing the very strict the glycemic control here. So we are aiming for HbA1c target of less than 8, and the decision to treat with statin have to be individualized. Moving to the very complex group with very limited remaining life expectancy. The focus here is to provide the quality of life in their later, maybe the later part of the end of life, not to achieve any targets with regard to glycemia, blood pressure, or the lipids, but to avoid 2 extremities of the glycemic control, that is both hypoglycemia and the symptomatic hyperglycemia. So in summary, with regard to diabetes management in the elderly, screening for diabetes complications should be individualized. So if you are depending on their frailty level, their functional status, and the cognitive status. If at all, if you have decided this patient needs screening, pay attention to the complication that would lead to impairment of their function status, focus on the vision and the mobility, the sensory impairment. So they needs the screening priority. Optimal nutrition and protein intake and regular exercise is recommended. So otherwise fit and well individuals, aerobics, strength training are indicated if the patient can take these things very well. Medication with low risk of hypoglycemia are preferred. Metformin is still the first line. And sulfonylureas are associated with hypoglycemias and should be used with caution. Thiazolidinones should be used very cautiously. It's better avoided. They are associated with nasty side effects in the old age. Incretin-based therapies, SGLT2 inhibitors, are very well taken up by this population because they have very few side effects, but maybe having the LG2 inhibitors with UTI. Otherwise, they are very well taken up. Only once-day therapies, minimal risk of hypoglycemia, and added cardiovascular benefits should be considered in your ideal patients. The use of insulin therapies require that the individual or the caretakers to have good visual and motor skills and the cognitive abilities. However, at least, these patients, some of the, at least, certain proportion of your patients, the elderly patient with diabetes having, longer duration of diabetes must be on, couple of the many kind of oral hypoglycemic agents, still with struggling to achieve the, reasonable control. It's better to think about putting them on at least once daily basal insulin injection therapies. That's a good option to be considered. Moving to the next topic of the day, hypertension in the elderly. Nearly half of the adults over 50 years diagnosed with hypertension, and over 70% people over the age of 65 have high blood pressure. A substantial proportion of individuals with hypertension remain undiagnosed. Significant proportion of the diagnosed do not receive the proper treatment, and even though they are on treatment, 1/3 of the hypertensive individual, they do not meet the targets. So these are from the recent research evidence. Right, so how hypertension relates to the complications? It's related to high cardiovascular morbidity and mortality. And with regard to my population, the geriatric population, it is the systolic blood pressure, not the diastolic blood pressure, is linked to the cardiovascular morbidity and mortality. So high systolic blood pressure and isolated systolic blood pressure are strong risk factor for cardiovascular morbidity and mortality in this population. The physician's failure to recognize the need to achieve the good blood pressure targets in this population is the barrier to achieve the control, the targets. However, achieving the blood pressure targets in this population reduce cardiovascular morbidity and mortality, reduce progression to the chronic kidney disease, progression of the chronic kidney disease, and reduce stroke-related cognitive impairment and dementia. Right, so this is the global trend. This graph shows the clear global trend of increasing hypertension prevalence with age in both sexes, becoming a major health concern in older population. So what's the Sri Lankan situation? So this, you can see in the bottom, the people, the age range between 60 and 69 and 70 and 79. The percentage of people with hypertension is 74% and 80% respectively in the year 2018. This is according to the guideline based on ACC. So it's huge. Right, so what's the recommendation for management of hypertension in the elderly? So this is ESC 2024 guideline. So they recommend to treat the elevated blood pressure in the older adults or less than 85 years who are not moderate to severely frail, follow the same guideline as for the younger people, provided the blood pressure lowering treatment is well tolerated. So what do they emphasize? The elderly population need to be treated as the younger population if they are otherwise fit and well, and if they take this blood pressure lowering drug very well. So this is level 1 class A recommendation. Right. So I want you all to draw your attention to this graph. This slide illustrates the evolution of blood pressure goals in pivotal clinical trials for hypertension in the elderly over several decades, from 1985 to 2016. Earlier trials historically aimed for a relatively higher systolic blood pressure goals around 140, 150. And the guidelines were based on these trials, and we went for a higher blood pressure targets for the elderly, like 140, 150. The SPRINT elderly trials, was conducted in 2016, stand out with a significantly lower systolic blood pressure goal of 120. They compared this 120 intensive blood pressure low target group versus the standard blood pressure group of less than 140. And they found out that this intensive arm has 25% reduction in all-cause mortality and 27% reduction in the primary outcome of adverse cardiovascular event at the 3.6 years. So it's a landmark trial. And this crowded the slide further highlights several other landmark trials and translates their findings into clinically meaningful metrics, the number needed to be treated. So I want you all to pay attention to the top part of the table. So there's another trial called STEP trial, systolic blood pressure intervention trial in patient. So this is called a STEP trial. It also a randomized open label trial. They are the intensive group aim for a systolic blood pressure of less than 130, and the standard blood pressure group less than less than 150. So the STEP trial as well as the SPRINT trial both have found that the intensive group with the remarkable improvement, the remarkable beneficial effect in reducing the cardiovascular morbidity and the mortality. And the number needed to be treated to prevent one adverse outcome with regard to the primary outcome. It was 86 in the STEP trial at the end of the 3.6 years, and the SPRINT trial, it was 45. When you pay attention to the bottom part of the table, that the HIVET trial and the SPRINT elderly trial, the HIVET trial is a randomized double-blind placebo-controlled trial. So they compared the standard treatment against the placebo arm. The standard treatment, they aimed the blood pressure target of 150/80. Here, they again showed that just blood pressure control has a beneficial effect against preventing this cardiovascular morbidity and mortality against placebo. And all these trials showed that there's a beneficial effect in lowering blood pressure in elderly. However, this STEP and the SPRINT trial has added benefit of they have shown the huge population. They have the STEP trial, they have the population of 9,000. The SPRINT trial, they have population of over 10,000. So multi-centered. They have added, they have included the elderly with intensive arm and showed that the number needed to be treated to prevent adverse cardiovascular event or the prevent a death. The elderly people need to be treated is much lower than the placebo control trial. Right. So this slide summarizes the current blood pressure targets in older age. So now we are moving from the standard treatment. So the standard blood pressure targets to intensive blood pressure targets, depending on focusing on the current evidence. So the ACC/AHA as well as the ESC 2024 both aim for the less than 130/80 for otherwise fit and active older adults. So here I have included the 2018 ESC guideline, but the 2024 guidelines say that it should be ESC less than 130/80. Right. Moving to the antihypertensive pharmacotherapy for the elderly to achieve the targets. This as for the young population, it should be dual therapy with the low dose dual therapy to start with. These are the combination therapy you can go with as for the younger population. So what about the beta blockers? Beta blockers should be avoided as much as possible in the older adults unless it is indicated by the other comorbidities. However, there are some few exceptions for the initial monotherapy. They are the grade 1 hypertension. That's the patient's blood pressure belonging between 130, 140 systolic blood pressure, and moderate to severe frailty, symptomatic orthostatic hypotension, and very old age. Right, this is the flow chart from the SC, outlining a practical algorithm for pharmacological blood pressure lowering, particularly relevant to older patients. Right. So this table outlines key lifestyle modification recommended for managing hypertension along their approximate potential to reduce the systolic blood pressure. So what does it emphasize? The weight reduction, adaptation of DASH eating plan, and physical activity. Right. So this chart is very important, and this flow chart provides a guide to managing blood pressure in older adults stratified by their frailty status using clinical frailty scale. So that helps summarize all what I have said so far. Say they asked to follow the BP lowering treatment guidelines similar to younger population. Intensive blood pressure, the lowering might be considered in fit and otherwise well patient with the low frailty level with the evidence of cardiovascular benefit. Moving to another significant part of hypertension, especially in elderly population, the ISH, isolated systolic hypertension. So what is ISH? ISH is defined as the systolic blood pressure of 140 or more with normal diastolic blood pressure. It is the most common type of hypertension in old age. And since most older patients with hypertension have ISH, with advance in age, the risk of cardiovascular disease, the events are driven by the systolic blood pressure rather than diastolic blood pressure. So the management of ISH in older adults is broadly in line with that of the management of combined systolic and diastolic blood pressure management in younger adults. So therefore, therapeutic inertia in older patients with ISH should be avoided. So they need to be treated to avoid the adverse cardiovascular morbidity and mortality. So these are the take-home messages with regard to hypertension management in elderly. So dietary sodium restriction is recommended with evidence. Intensive blood pressure control is encouraged in otherwise fit and well older adults, irrespective of their age, because of the added cardiovascular benefit and cognitive benefits. And it is recommended to use home BP monitoring and telemonitoring. These are the effective tools for facilitating the antihypertensive drug titration, leading to better achievement and maintenance of blood pressure goals. Right, moving from to non-communicable disease, which is very prevalent in this age group, to the muscle loss with aging, we call sarcopenia. So it is the age-related loss of muscle mass, strength, and physical function, which we'll be discussing from here onward for next 10 minutes or 5 minutes. I have only 5 minutes left. Right. So what is sarcopenia? Is it prevalent? So sarcopenia in elderly, what will happen to our muscle mass with aging? So we tend to reduce our lean body mass and replace that with fat mass. Right, so this is a tale of the leg. So what is happening to your muscle with aging? It's going to be thinner and thinner, replaced by fat and fatter. Right, so it is common? Yes, it's very common. 25% in the people over the 60 and 60% in the people over the 80. So it's a vicious cycle. When you have less muscle mass, sarcopenia, so you tend to be very fatigued. When you start doing a physical activity, then you tend to ignore physical activity. Then in turn, it aggravates the sarcopenia. So what are the consequences of sarcopenia? It leads to a lot of adverse events, including increased risk of falls, disability, osteoporosis, fractures, the cognitive impairment, the cardiovascular diseases, type 2 diabetes, fatty liver, and you will have the cancer outcome will be poor. Ultimately, you will have very poor life expectancy. So it's very important to deal with the sarcopenia and prevent, and if at all, if you have diagnosed, treat this disease modality to overcome these complications. So according to 2018 operational definition, there are 3 types. So that means the probable sarcopenia and the confirmed sarcopenia, as well as the severe sarcopenia. So probable sarcopenia is defined based on the criteria 1, that's the low muscle strength. The sarcopenia is confirmed when you have criteria 1 and 2. That means low muscle strength plus low muscle quantity or quality. When all 3 criteria are met, then you have the severe sarcopenia. That means you have low muscle strength, low muscle quantity or quality, along with low physical performance. Right. So this flow chart outlines the practical algorithm for identifying and assessing sarcopenia in clinical practice. So it involves a stepwise approach. You have to first find the cases, or you have to either clinically suspect or screen the patients to identify who will have sarcopenia. So the sarcopenia screening is done by using the screening tool we call SARC-F screening questionnaire. When the patient has these possible the screening is positive, then we have to assess their muscle strength to see whether they have the probable sarcopenia. So there are certain tools to be used, grip strength, chair stand test. If it is possible, the patient, the positive, then the patient has probable sarcopenia. Then you have to confirm sarcopenia by assessing the low muscle quantity or quality. For that, we use imaging techniques like DEXA, BIA, CT, or MRI. If the sarcopenia is confirmed by these modalities, then we have to assess whether the patient has severe sarcopenia by performing one of these tests, gait speed test or tuck test or 400 meters walk test. If it is confirmed, then the patient has severe sarcopenia. Right, so this is a screening tool used to screen the sarcopenia. We call it SARC-F. It has 5 components. So this is the Sinhala validated SARC-F questionnaire. It is being validated. It's very simple to be used in clinical practice. So these are the area of investigation we carry out to assess the muscle mass, strength, and the physical performance. So these are the investigation we do. Right. So when it comes to the management, the last part of the lecture. So sometimes the sarcopenia is, most of the time it is primary. There's no underlying cause, age related. You can't reverse the age, but it is coming with the age. But sometimes something can be due to secondary, due to the illness, malignancy, or nutrition, right? If it is there's underlying cause, you have to treat the cause. Otherwise, the physical activity is the mainstay of treatment. So the exercise. The exercise has been shown over and over again, the cornerstone in the treatment of sarcopenia. So what I want to highlight here is the strength training that has been shown as the powerful intervention that helps preventing as well as the treating the sarcopenia at any age, particularly in old age as well. So the goal is to progressively overload the muscles to increase the muscle fiber size, number, and function. These to improve strength, power, and endurance. So this is the resistance exercise prescription to start with. And what about the aerobics? They are very good at aerobics, right? Cardios. Are they not at all good? No, they are less, though they are less effective for muscle hypertrophy than resistant training. It does stimulate some muscle protein synthesis, and it reduces the body weight. So there is some functional role relative to because it reduces the body weight. All right. So this slide powerfully shows that strength training is the key weapon against age-related muscle loss, slowing down towards the disability. right? So you can fight against the age when you engage in the strength training. Combining it with the cardios, combining it with the cardios, but it gives the best result for healthy aging. So there are some evidence for the nutrition, the increased protein intakes, at least taking the daily requirement of vitamin D. And we come to the last slide, the summary. So globally, prevalence of diabetes in the older age is 25% and hypertension is over 50%. Each older adult with diabetes and hypertension should undergo cognitive and functional assessment. And management should be individualized according to their cognitive and functional status. Avoiding hypoglycemia is more important than achieving the optimal high HbA1c targets. Therapeutic inertia in treating high blood pressure in otherwise fit and healthy adult should be avoided. Treat the older adult, not the blood pressure value, HbA1c target, the HbA1c report, or the lipid profile. Sarcopenia need to be integrated to clinical practice in older adults. Sarcopenia is common than you think and is related to all the adverse health outcomes in aging. Resistant training should be encouraged in treating and preventing sarcopenia. Thank you.
Thank you, Dr. Varsha. Are there any questions?
I think commonly we see hypertension among the older population. From the young age to middle age, we try to bring some control and then that. So the more and more other market will also have some. But I think about hypertension prevention.